Hello, everyone, and welcome to the CPS 101 lecture on crude measures of effect and association and appraisal of results from RCTs. So we initially started off by learning about how to conduct a randomized controlled trial in RCT or a phase 3 study. And we learned about how to critically appraise the study design of an RCT for a published trial study. And you would have learned a little bit more about statistics by the time you listen to this lecture. So now we're going to talk a little bit about how to interpret the results of randomized controlled trials, and then how to calculate some of the different effect measures that you need to know about for your RCT projects, and how to determine the results of a particular study. So there's lots of different measures of interest and occurrence that we're going to go over in this lecture. But just keep in mind, this is all related to figuring out what the results of a study are, calculating them for yourself, or interpreting the results of a randomized controlled trial, and then understanding what the effect of the study drug is that you're looking at. So you're going to be answering your research question essentially with these measures of interest and association. So you're going to answer the question whether or not a medication has an increased or a decreased risk of a particular outcome compared to what your comparator is, or another study medication. So just keep that in mind. Why we're learning about all this in the first place. It's in order to answer our research question. Is drug A associated with a particular risk of an outcome compared to the comparator? So our first measure of interest that we're looking at, so think of this as our patient population that we're following in our randomized controlled trial. We've got our entire group of patients that we've randomized the intervention and control group, and we started following them forward in time to see if they've experienced our outcome of interest. And so we want to determine how many people were followed, how long were people followed for, and how many people had the outcome. Those are some initial measures of interest. So our first measure of interest is a measure of occurrence, and it's called risk. So risk is calculated as the number of cases of a disease or a particular outcome divided by the total number of people at risk. So risk is essentially a probability, and it's meant to apply to a particular time period. So you can calculate a risk that applies to a 5-year time period. So in this particular example, where we have 10 people and we have two outcomes of whatever disease we're interested in studying, the risk is 2/10 or 0.2 or 20%. So we'd say that 20% of individuals followed over a 5-year period had the disease or the outcome of interest. So that's one of our measures of interest. It's a measure of occurrence called risk, where the denominator in this particular measure is people, number of persons. And we assume when we're calculating risk that each individual in our cohort is followed for the same amount of time. That's an important assumption when you're calculating risk. Another measure of occurrence is the incidence rate. So the incidence rate is calculated as the number of new cases of a disease over the total person time of follow-up. So person time is essentially just the time that each person spends in follow-up until they experience the outcome of interest or until they're lost to follow-up. So considering person time is especially important because you're able to account for different periods of time that you're observing each individual for that's part of the study. So you're not assuming that each person is followed for the same length of time. You're able to incorporate differential follow-up times into your measure of occurrence. So we assume that people are no longer at risk of the particular outcome or disease that we're looking at once they experience the outcome, and thus they stop contributing to the total person time at risk. So this is just an example of how following an individual forward in time, and then they experience the event of interest. This person here is followed for 3 years as well, but they don't experience the event of interest. It just goes to show that there can be differential follow-up time for each patient or individual in your study, and then you can see that each individual may or may not have the outcome of interest. So that's another measure of occurrence. So this is just how you would calculate the incidence rate in this particular example. So you add up all of the time at risk for each patient. So you'd add up 3 plus 3 plus 3, et cetera, for each patient in terms of the total person time. There's 2 cases of the disease, 1 case here and 1 case here. It's 31 years is the total follow-up time for all the individuals in the cohort. The incidence rate is calculated, as I mentioned, as the total number of cases of a disease or an outcome divided by the total person time. So in this case, our incidence rate is 2/31, 0.06. So this is 0.06 events per person year of follow-up. That's the units on this particular measure, events per person time of follow-up. So just a reminder that in this measure, our person time, or our denominator is person time, and in our risk measure, our denominator was people. So that's an important distinction between the difference between rates and risks. So that's another example of a measure of occurrence that we can calculate in our study. So it's the measure of occurrence for the outcome of interest that we're looking at. So other measures of interest that we want to calculate when we're conducting a trial is, or analyzing the results of the trial is, how many people were exposed to drug A, and I'm using drug A and drug B as an example just to make these measures a little bit more clear. And by drug A, I mean the intervention group. That's what I'm referring to as the intervention. And drug B, I'm referring to as the comparator. So just a reminder that the comparator doesn't have to be another medication. It can be placebo in an RCT. But yeah, just know that drug B, by drug B, I mean the comparison, the comparator group, and drug A, I mean the intervention group. So you want to calculate how many people were, and it's exposed, but it's randomized, essentially randomized to drug A and drug B. And then how many people were randomized to drug A and then had the outcome. And then how many people were randomized to drug B and had the outcome. So I understand that it's a bit frustrating sometimes that there's different terminology for all these different things you're learning about, but that's kind of the reality of the field. So it's important to understand what other names certain concepts can have, just so if you don't hear the same word all the time, you'll be able to recognize it as something else, So that's, try and keep the terminology consistent, but just so you can understand in a different context. If they're using different words to describe something, you'll understand what it means. So when we know, how many people were exposed to drug A and drug B, how many people had the outcome, and then how many people exposed to drug A had the outcome, and how many people exposed to drug B had the outcome, we can actually arrange this information in something that we've called a 2x2 table. So here we have the exposure on this side, drug A and drug B. Again, this is our intervention group, and this is our comparator group. And for the outcome, this is our disease of interest, or the outcome of interest for the trial. We have yes, no. So we have these cells here that we call A, B, C, and D. And A is always, intervention had the outcome. B is intervention group didn't have the outcome, and so on. So these are the counts of people that are in each of these categories within your study. And then, of course, you can add them up into these different combinations. So everybody that has the outcome, that's going to be cells A plus C. And then anybody who was exposed to the intervention or drug A, that's going to be A plus B. So that's what I mean by a 2x2 table. So using this 2x2 table, we can answer the question, what was the occurrence of the outcome more likely among those taking drug A compared to those taking drug B? So we need to be able to measure something like a disease rate or a risk or an odds in those exposed to drug A, and then compare those to those exposed to drug B to determine if the exposure or the treatment is actually associated or causes that particular count. So occurrence of the disease. So this again is a disease rate, risk, or odds. So this will make a little bit more sense in the next slide. So measures of association that we want to calculate in order to answer that question. Was the occurrence of the outcome more likely among those taking drug A compared to those taking drug B? We can calculate things like risk ratios, incidence rate ratios, risk differences, and rate differences. So I'll get into the specifics of those. So risk ratios and risk differences. So a risk ratio can also be known as a relative risk. So just keep that in mind. Risk ratios and relative risks are the same thing. So again, we're going back to our 2x2 table here, where we have the exposure status on one side and the outcome status on the other side. And if we want to calculate a risk ratio to determine whether the risk of the outcome is higher among those taking drug A compared to drug B, what we need to do first is calculate the risk of the outcome among those taking drug A. So this is going to be calculated as A, cell A, or the count in A over A plus B. And A plus B is the population initially at risk that are taking drug A, so initially at risk of the outcome. So this is this group here, A plus B. And the number of events among those taking drug A is just cell A, which is right here. And then in order to calculate the risk of the outcome among those taking drug B, we need to first determine the population initially at risk that are taking drug B. So it's cell C plus D. And then you need to determine the number of events among those taking drug B, which is just cell C right there. Excuse me. So then the risk of the outcome among those taking drug B is just going to be C over C plus D. So then in order to calculate the risk ratio and the risk difference, we can simply just subtract the risk of the outcome among those taking drug A minus the risk of the outcome among those taking drug B. That's how we would calculate the risk difference. And then the risk ratio is the risk of the outcome among those taking drug A divided by the risk of the outcome among those taking drug B. So that's how we would calculate a risk ratio and a risk difference. A rate ratio and a rate difference, it's very similar, but rather than calculating risks, we're calculating rates. And recall that a rate is incorporates person time into the measure. So first we have to calculate the rate of the outcome among those taking drug A. So this is simply calculated as A, which is the number of events among those taking drug A, divided by the total person time among those taking drug A. So total person time of follow-up among those taking drug A is just that, the total person time within those taking drug A. And then A stays the same. It's the number of events among those taking drug A. And then for the rate of the outcome among those taking drug B, it's the same thing, the number of events among those taking drug B divided by the total person time of follow-up for those who are taking drug B. And then you can calculate, the rate of the outcome among those taking drug A, and then the rate of the outcome among those taking drug B. And then the rate ratio and the rate difference can be calculated very similarly to the risk ratio and the risk difference. So that's how we calculate a rate ratio and a rate difference, and a risk ratio and a risk difference. So then after we've calculated these measures, well, how do we actually interpret them? So for the ratios, again, we're always comparing drug A to drug B. It's always the risk in the drug A group minus the risk in the drug B group, or the risk in the drug A group divided by the risk in the drug B group. So it's always A compared to B. So that's important to remember when we're actually trying to interpret these measures. So if we have a ratio, or which could be a rate ratio or a risk ratio, if it's greater than 1, that indicates that the risk of the outcome is higher in the intervention group compared to the control group. So it's higher in the drug A group compared to the drug B group. If the ratio is less than 1, that indicates that the risk of the outcome is lower in the intervention group compared to the control group. And if it's equal to 1, that means that there's no difference in the risk of the outcome between the two groups. So that's pretty simple, and it's just basic math. Now, if we're trying to interpret the differences, if the rate difference or rate or risk difference is greater than 0, means that the risk of the outcome is higher in the intervention group compared to the control group. If it's less than 0, it means that the risk of the outcome is lower in the intervention group compared to the control group. But if it's equal to 0, it means that there's no difference between the two groups. So the null value for ratios is 1, meaning that the risk of the outcome is the same between the two groups. And then, of course, the null value for a difference is 0. It means that there's no difference in the risk of the outcome between the two groups. So if we determine that our relative risk is greater than 1, then we would tend to calculate a relative risk increase in order to interpret this value. So a relative risk increase is just 1 minus the relative risk. So for example, if we have a risk ratio of 1.65 for the risk of the outcome among drug A compared to drug B, or among those taking drug A compared to drug B, again, intervention group, control group, we would interpret this risk ratio of 1.65 as meaning that drug A is associated with a 65% increased risk of the outcome compared to drug B. So that's how I would interpret a risk ratio of 1.65. If the relative risk or risk ratio is less than 1, then I'd calculate a relative risk reduction, which again is the same. It's just 1 minus the relative risk. So if I have a risk ratio of 0.65 for the risk of the outcome among drug A versus drug B, I would interpret that as drug A is associated with a 35% decreased risk of the outcome compared to drug B. So again, I can say whether the risk of the outcome is higher or lower in the intervention group compared to the control group based on the value of the risk ratio or the risk difference, or the rate ratio or the rate difference. And then this is specifically how I would interpret those particular values. So it's important to keep in mind what the difference between the risk ratio and the risk difference is, and also that it's important to typically calculate both in whatever study you're looking at, or to look to see whether they've calculated both a risk ratio or a risk difference, or an absolute measure and a relative measure of effect within a particular study that you're looking at or conducting. And this is because the risk ratio always tends to be larger than the risk difference, and presenting the risk ratio alone can actually convey very misleading results. And it's really important to consider what the baseline risk of your outcome is in a particular population you're looking at. So in a randomized controlled trial, the baseline risk is just the risk of the outcome in the control group. So I think this graph will illustrate the point further. So in this particular example, all three populations have a risk ratio of 0.33 for the effect of drug A compared to drug B. But in this population, the risk difference is 0.2, where the baseline risk of the outcome is 30%. This is the control group here, and then it's reduced to 20% in those in the treatment group. So the risk difference is 0.2. Same risk ratio here. This is still a risk ratio of 0.33, but the baseline risk of the outcome is much different. It's only 10%. And you can see here that the risk difference is only 0.067 for drug A within this population compared to drug B. And in this population, where the baseline risk of the outcome is very, very low, with a risk ratio of 0.33, just means that the risk difference is actually 0.0067. So if the baseline risk of the outcome is very low, then it actually means that the overall effect of the treatment is also going to be low, because there's already a very low risk of the outcome to start off with in a particular population, but then the risk ratio remains consistent across these three populations, when actually, the importance of the treatment in a given population does depend on the baseline risk. So just important to report both the risk ratio and the risk difference, or the absolute risk, when you're conducting an RCT or presenting the results, or interpreting the results of the study. It's also important to calculate the number needed to treat and the number needed to harm. So we're going back to our 2x2 table here. So the number needed to treat is defined as the number of patients you would need to treat to prevent an adverse event. And this is in the case that the intervention reduces the risk of your outcome of interest. And you also want to calculate the number needed to harm. And this is going to be the number of patients you need to treat to cause an adverse event if the intervention increases the risk of an outcome. And this is typically when we're looking at the risk of an adverse event. So the number needed to treat or the number needed to harm is calculated the same way. It's just 100 divided by the risk difference, where the risk difference is expressed as a percentage or a whole number. It's not a number that's less than 1. So that's how you calculate a number needed to treat and a number needed to harm. So just a quick note on confidence intervals. So you would have touched on this a bit in your statistics lectures, but I just want to go over what confidence intervals mean in the context of measures of association. So as you learned, confidence intervals are based on statistics, and they're a function of the standard error in a particular study and the sample size. So the definition of a confidence interval is that if a researcher or researchers were to repeat a study 100 times, 95 times out of the 100, the measure of association calculated would fall within the range of the confidence interval that's given for a particular study. That's what the definition of a 95% confidence interval is. So it's important to evaluate whether or not a confidence interval includes the null value or not when you're interpreting your measure of association. So for example, let's say we're looking at a measure of association that's 1.2. So this would indicate that there's a 20% increased risk of the outcome among those in the intervention group compared to the control group, for example. But we have 3 different confidence intervals. So let's say the first confidence interval ranges from 0.2 to 2.0. So the null value for a risk ratio is 1. So we can see that 1 is included in this confidence interval, and that the confidence interval is very, very wide. So, if we were to repeat this study 100 times, 95 times out of 10, the relative risk that's calculated would fall within this range. So it doesn't have a lot of precision, this particular confidence interval. So we wouldn't be completely confident as to whether or not a particular treatment increased or decreased the risk of an outcome. So even though the relative risk is 1.2, based on that confidence interval, we couldn't say one way or another whether or not the intervention either increased or decreased the risk of the outcome, because the confidence interval is so wide and really does span the null value. But if we looked at this confidence interval here, which ranges from 1.1 to 1.5, the entire range of the confidence interval is above the null value. So we'd be a lot more confident in suggesting that, the intervention group did indeed increase the risk of the outcome compared to the control group. In this situation here, where the confidence interval ranges from 0.99 to 2.0, yes, the confidence interval does include the null value of 1. However, it mostly falls over higher than the null value. So, we might be slightly less confident that there's an increased risk of the outcome with the intervention compared to the control group, looking at this confidence interval compared to this one. But they're pretty similar with respect to the precision and the range. So, we should still say that, okay, it's still likely, even though this confidence interval includes the null, it's more likely than not that the intervention group does increase the risk of the outcome. So that's kind of how you would interpret this relative risk or this risk ratio in conjunction with these three different confidence intervals. So it is important to point out that it's best practice to interpret the results in the context of the confidence interval, not p-values. So that's important to understand when you're reporting the results of your study for your randomized controlled trial project, as well as when you're looking at the results of a published RCT. It's also important to think about what a clinically important difference is. So just because a confidence interval does not include the null, we need to ask ourselves, does it mean that the measure of effect is clinically important? Well, not necessarily. Whether or not a measure of effect is clinically important really depends on the disease and the outcome being studied. It's context specific, and it doesn't necessarily depend on statistical interpretations. So you can have a relative risk, like I said, of 1.2, and maybe your confidence interval is the 1.1 to the 1.5 value. So you're statistically pretty confident that there is indeed an increased risk of the outcome in the intervention group compared to the control group. But whether or not that 20% increased risk of the outcome is clinically important or clinically meaningful does depend on the disease that you're studying. And typically, a clinically meaningful difference or is typically a threshold value for which any change as large or larger than that value is considered clinically meaningful to patients or clinicians or both. So again, for example, like a 2% reduction in blood pressure levels may not be clinically important, whereas a 2% reduction in pain levels might be for patients. So there's no hard and fast rule with respect to a threshold that applies to every situation for a clinically meaningful difference, but it really depends on the disease you're studying, the treatment, whether there's alternatives, and typically that's informed by clinical context. It's not usually something that you can, just pick off the top of your head. So that's important to understand, is that, even though you've interpreted your results, statistically, the clinical meaning or importance of that interpretation needs to be further assessed. Excuse me. So now we want to think about this in terms of critically appraising the results portion of an RCT. So in my previous critical appraisal lecture, I focused on study design, since you hadn't learned about statistics yet and you hadn't learned about these measures of effect or measures of association. But now I think that you have a bit more knowledge in this area. We can talk about critical appraisal of the results section of randomized controlled trials. So what we want to understand when we're interpreting and appraising the results section of RCTs, we need to understand what the results of the study mean, and then relate it back to our study question. So this is, again, our PICO question. We'd be asking, is there an increased risk of heart failure, for example, among those taking the intervention drug compared to those taking the control drug? Again, all of these measures of association that we just looked at, and then the confidence intervals around those, help to answer that particular question. Is there an increased risk or a decreased risk of a particular outcome with the intervention drug compared to the control drug? So we have to ask ourselves, what are the results? So the first question we want to answer is, how large was the treatment effect? And in order to answer that, we need to calculate the risk ratio and the risk difference for the effect of the intervention or drug A on the outcome compared to the control group or drug B. So then we interpret these measures with respect to a percent increase or reduction or no difference in the outcome for the intervention group compared to the control group. So again, back to what we learned, we calculate our risk ratios, our risk differences, or our rate ratios, or our rate differences in order to calculate that and determine how large the treatment effect was. Then we need to ask ourselves, how precise was the estimate of the treatment effect? So in this particular situation, we need to look to see how wide the confidence intervals are and whether they include the null values for the measure of effect or not. So going back to our risk ratio, we have to look to see whether the confidence interval includes 1 and how wide that confidence interval is. And we also want to look to see whether or not, if we're looking at the confidence interval for a risk difference, whether or not the confidence interval includes 0, and then again, how wide that particular confidence interval is. And we also need to think about whether or not the treatment benefits are worth the potential harms and costs for a particular medication. So we need to calculate the number needed to treat and the number needed to harm in order to answer that question. So as I mentioned, we need to evaluate the benefits of the treatment, but we also need to evaluate the potential harms. So a given treatment or new study drug might reduce the risk of myocardial infarction, which is important and is a benefit, but it also might increase the risk of cough, which, you know, is a harm after all, and obviously not as severe as experiencing a myocardial infarction, but still important to be able to balance the risk and benefits of a treatment. So in order to do this, you calculate the number needed to treat and the number needed to harm, and then you compare the two measures to weigh the risks and the benefits of treatment. So again, typically you need clinical expertise and patient input to be able to interpret these adequately. And then you also need to understand the patient's baseline risk and what the relative risk reduction is associated with the treatment in order to determine whether a patient should be prescribed a given medication. So if the baseline risk of an outcome is very low in a patient population and the relative risk reduction is also quite low, and then the number needed to harm is maybe a little bit high, that might be a really good reason not to prescribe a study drug to a particular new medication to a patient. Or it's a new medication, but it's been approved for use on the market. So that's an important consideration when we're trying to weigh the risks and the benefits of a treatment for a patient, and also important when, again, we're interpreting the results of the study, or you're interpreting the results of your own randomized controlled trial. So that is the end of this particular lecture, and I am happy to answer any questions about this in our next seminar. So have a great rest of your day.